I'm Ron Berkman. Today we'll be discussing nausea and vomiting in pregnancy, treatment fit for a queen. This particular lecture is divided into two parts, and each part will cover a certain amount of the topic. Before we get started, I do want to indicate that I have nothing to disclose. I received no remuneration for preparing this lecture or putting it on the format that you're now viewing. At the end of the presentation today, you should be able to describe the epidemiologic features of the disorder, and that includes nausea and vomiting of pregnancy, as well as hyperemesis gravidarum, as well as list possible etiologies, and include again how to do some of the workup. In the second lecture, you will be presented with various treatment approaches and how to utilize an algorithm for the management of such patients. If we look at the history of the disorder, the first description of the disorder was by Cyrenus in the 1st or 2nd century AD. He was a Greek physician from Ephesus who wrote a 4-volume gynecology text. Also of historical note is that a number of notable English women have suffered from the disorder, and we'll talk about some of these women shortly. And finally, more importantly, was the demise of bendectin. This is a drug that contained 10 milligrams of doxylamine and 10 milligrams of pyridoxine. In 1982, was taken off the market in the United States, and this had significant ramifications for treating women with the disorder, both nausea, vomiting, as well as hyperemesis. If we look at some of the history among English women, this is a picture of Charlotte Bronte. She was the oldest of the 3 Bronte sisters and wrote the book Jane Eyre, which many of us have read either in high school or college. However, unfortunately, she died at the age of 38 in the 4th month of pregnancy due to intractable vomiting and dehydration. It was felt the cause was hyperemesis, though there are some people that feel possibly typhus was the cause. This is obviously Queen Victoria. She had a reign of 63 years and 7 months and had 9 children, but she felt breastfeeding was disgusting and she thought babies were ugly. However, to manage her nausea vomiting symptoms during pregnancy, she utilized marijuana. And finally, most people are familiar certainly with Kate Middleton, the Duchess of Cambridge. She married Prince William in April of 2011, and with her first pregnancy was hospitalized for 3 days in December of 2012 for treatment of hyperemesis. This stay unfortunately was marred by invasion of her privacy and by the suicide of one of her caregivers. The demise of bendectin certainly is a sad story. In the late 1950s and 1960s, it was the most widely prescribed drug in the United States for nausea and vomiting in pregnancy. However, in the 1970s, multiple lawsuits against the manufacturer occurred, claiming that the drug was teratogenic. However, many of the studies were not well done, and even those that were well done really did not show any increased risk of major malformation of fetuses. Yet the lawsuits persisted, such that in 1982 the manufacturer withdrew the drug due to the extraordinary expense of defending the suits. Diclectin, with the same formulation, continued to be marketed in Canada. And if we look at the Canada experience here on this particular graph and look particularly to the far left, you can see at the top you can see what happened with bendectin. In the 1981-1982 era, the use of the drug started to decline. This was probably on the basis of some of the reports that got into the press. And when it was withdrawn from the market, obviously there was a steep decline. If you look also at the hospitalizations starting in 1980, certainly they were very low with the utilization of bendectin, but when it was withdrawn from the market, you can see there was a steady climb to a much higher rate of hospitalization for excessive nausea, vomiting, and pregnancy. At the same time, diclectin was introduced, which basically is the same drug as bendectin, and it took a number of years for its use to become more substantial, primarily because of bad publicity. But by the early 1990s, when more and more data indicated that the use of this combination did not cause teratogenicity in fetuses, you can see the use of diclectin increased, At the same time, the hospitalizations for excessive vomiting in pregnancy decrease, again showing this important interaction between withdrawal of the drug and reinstitution of the drug. So how do we define these disorders we're discussing? Nausea, vomiting in pregnancy has no uniform definition, and it's based primarily on patients' perception of symptoms and their desire for treatment. And when they report for treatment, this usually results in it being diagnosed by the care provider. Hyperemesis gravidarum has common criteria and usually include persistent vomiting without another cause, acute starvation usually manifested by ketonuria on urinalysis, and weight loss of 5% or greater of the pre-pregnancy weight. If we look at the epidemiology of nausea and vomiting in pregnancy, 50 to 80% of women will have nausea in the early pregnancy, with about 50% of women with retching and vomiting. Onset is usually 4 weeks after the last menstrual period and tends to peak at 9 weeks. So a sort of important landmark here. 60% of women have symptoms that resolve after the first trimester, but some it will persist, but almost all will have elimination of symptoms by 20 weeks of pregnancy. It appears to be less common in older women, less common in smokers, perhaps related to decreased levels of estrogen, and less common in multiparous women. The risk of spontaneous first trimester abortion is also reduced in studies of women with nausea and vomiting in pregnancy for reasons that are not fully understood. Hyperemesis gravidarum, it has certainly a far lower incidence, which ranges between 0.3 to 3% of pregnancies. However, it's the most common reason for hospitalization in the first part of pregnancy, though hospitalization is less common in obese women. With a prior history of hyperemesis, up to 20% of women hospitalized with it previously will be hospitalized with it in a subsequent pregnancy. These women also often have electrolyte, thyroid, and liver abnormalities. The potential complications of nausea, vomiting in pregnancy and hyperemesis are listed here. They can include depression of the mother, esophageal rupture with severe vomiting, and also with esophageal tears, known as Mallory-Weiss tears. You can get pneumothorax with severe dehydration. Acute tubular necrosis can occur. And even Wernicke's encephalitis has been reported, and there has been some deaths associated with the encephalitis. Fortunately, the fetal effects are not significant. Yes, you can have low birth weight when there's hyperemesis, but not with nausea, vomiting, pregnancy. But there's no increase in malformations, and there is a decreased risk of spontaneous abortion. Here's a picture of a Mallory-Weiss tear in a woman who had hyperemesis. Now, there are numerous theories on the etiology of nausea, vomiting, in pregnancy. Over the years, certainly psychologic factors or psychiatric factors had been proposed, but there are no studies that can document that, in fact, these are important or play a significant role in the etiology of the disorder, though some of the theories used to be conversion disorders or somatization disorders cause this particular problem, or it's a response to stress. Some feel that there is an evolutionary factor that goes in that it's a protective response against deleterious foods. This may be true, but it's not the major reason that one probably gets this disorders. Abnormal GI motility has been reported, and it's reported particularly in some hyperemesis cases. And certainly women who are pregnant oftentimes have an increased gastroesophageal reflux, such that they will have heartburn, which leads to nausea and occasional, obviously, vomiting. H. pylori has been also studied. However, most people with the infection don't develop symptoms. And even when there's a significant association, as in a study which showed over a threefold association with hyperemesis, it was unclear whether this represented active infection with H. pylori or prior infection. The role of estrogen and progesterone also has been implicated in that there's relaxation of smooth muscle and delay in GI transit time, which could certainly lead to a risk of nausea and vomiting. And clearly the symptoms appear to be more common when estradiol levels are high, yet when they peak in the third trimester, the symptoms at that point usually are far less or even absent. Finally, human chorionic gonadotropin has been linked to the possible etiology or an associated feature of these disorders. It's well known that molar and twin pregnancies with their increased trophoblastic mass, which makes HCG, are associated with increased symptoms and increased HCG levels. Also, when women who have similar HCG levels may or may not have the symptoms, it is felt that perhaps the symptoms are due to HCG isoforms or receptor mutations in the women who have symptoms as opposed to the women who don't. And it appears that HCG is certainly one of the areas of current study in terms of relationship to these disorders. And here you can see that when the HCG peaks around 9 or 10 weeks, you also see a peak in the symptoms of nausea, vomiting, as shown in this older study. However, despite all these studies, and they are numerous, there continues to be no conclusive evidence to support fully any one theory for the etiology of either nausea, vomiting in pregnancy or hyperemesis gravidarum. So what's the differential diagnosis? This is particularly important when symptoms begin after 9 weeks of pregnancy. And certainly in the GI tract, you have to consider appendicitis, hepatitis, pancreatitis, gastroenteritis, biliary tract disease, and peptic ulcer. But in general, the symptomatology is somewhat different. For example, with appendicitis, pancreatitis, biliary tract disease, you tend to get far more abdominal pain symptoms, whereas in hyperemesis or nausea, vomiting in pregnancy, mild epigastric discomfort is about all that you would see from a pain standpoint. In the genital urinary system, certainly pyelonephritis, stones, ovarian torsion, degenerating myomas can simulate the disorder, but in general, some of these disorders will have fever, which again, nausea, vomiting, pregnancy, and hyperemesis do not, and also pain in areas and of a significance not seen with hyperemesis or nausea and vomiting. Metabolic disorders, particularly diabetic ketoacidosis, can mimic the disorder, but again, these individuals many of the times clearly have been diagnosed with diabetes, and it's relatively easy to decide whether it's ketoacidosis as opposed to hyperemesis. Hyperthyroidism also can mimic it, and you should understand that individuals with nausea, vomiting in pregnancy or hyperemesis can certainly have mild thyroid dysfunction with elevation of thyroxine and a decrease in TSH, but usually not at levels seen usually in hyperthyroidism in pregnancy. Further, they do not have goiters. Neurologically, migraine and vestibular lesions certainly can simulate some of the disorder, but again, usually one can eliminate these with careful history taking. And finally, drug toxicity, psychologic, and even acute fatty liver are considerations. The latter, that is acute fatty liver, however, is only seen in the latter half of pregnancy and more likely into the third trimester. From the standpoint of evaluation, for most patients, particularly those who present with nausea, vomiting that's not severe, don't require any particular testing beyond obtaining their weight and comparing it to either their pre-pregnancy weight or weight at a prenatal visit, checking their orthostatic blood pressure if they've been vomiting significantly to determine whether or not they have become symptomatically dehydrated, as well as checking for urinary ketones. Certainly with persistence or evidence of true hyperemesis, one can measure the serum electrolytes, and oftentimes we'll see a low potassium, low chloride, the latter being due to the vomiting. The hematocrit oftentimes will show hemoconcentration, this also relating to dehydration. One can have some abnormality of the liver enzymes, especially ALT, but usually not to very high levels. However, the serum amylase and lipase can show up to 5-fold increases. However, even this degree of increase is usually far less than that seen in pancreatitis. And as I've already noted, you can have evidence of mild hyperthyroidism. If an ultrasound is done, it may identify twins or molar pregnancy, which would lead you to more likely suspect that some of the symptomatology, if not all of it, is basically hyperemesis or nausea, vomiting in pregnancy. So this concludes video number 1. As noted already, video number 2 will deal with the management and the medications that are utilized, as well as the use of algorithms for treatment of women with this disorder.